All right, hello everybody. So today I want to talk about my topic, which is management of lumbosacral radiculopathy. Let's get into it. So before we get into it and really understand what lumbosacral radiculopathy is, I want to talk a little bit about the most common causes and what it is and what it's not. So a little background: there's common terms that describe osteoarthritis. And sometimes people, a lot of times people think that degenerative disc disease and spinal osteoarthritis are the same thing. And I think it's important to realize that they're not. So degenerative disc disease is mainly talking about the intervertebral discs and that there's a progressive loss of elasticity and volume in the disc itself. And this causes narrowing of the intervertebral spaces. And this is mainly a radiologic diagnosis. It may or may not be symptomatic. In fact, in most cases, it's not symptomatic. Nevertheless, this is degenerative disc disease. Spinal osteoarthritis, on the other hand, is degeneration of the facet joints. The articulations between the successive spinal vertebrae. And this is due to cycles of joint stress, local inflammation, and then reaction of the tissues by forming subchondral sclerosis and osteophyte formation, just like in other joints of the body. And spinal osteoarthritis is a clinical diagnosis, and it's characterized by painful and range of motion limiting pain in the spine. And so here's some of the ways that spinal osteoarthritis can manifest, and also degenerative disc disease. So in osteoarthritis, we can get things like disc degeneration and osteophyte formation. And the disc degeneration is believed to lead to the formation of osteophytes, and also to help promote the development of spinal osteoarthritis by changing the way in which weight bearing is loaded onto the spine, mainly shifting the weight bearing from the vertebral bodies to the facets or the zygapophyseal joints. And so this is here, and it's also degeneration in the discs can lead to things like a herniation or a bulging out of the contents of the disc, the nucleus pulposus, through the annulus fibrosus. Now, and so this kind of gets into what is radiculopathy and what is not radiculopathy. So spinal stenosis is an impingement on the spinal cord, and it can occur from narrowing in one of three spaces: the spinal canal itself, which contains the spinal cord, the intervertebral foramina, through which the peripheral nerves exit, or the lateral recess, which are mainly found only found in the lumbar sections, and are these areas right before the intervertebral foramina or the neural foramina. And spinal stenosis is different than radiculopathy. It affects the spine, and it presents differently too, with neurogenic claudication, and also the pain of spinal stenosis is bilateral, tends to be bilateral, as opposed to radiculopathy, which tends to be unilateral. So it's important to keep that in mind. And now this narrowing of the spinal canal or neural foramina or lateral recess, it can be due to things like hypertrophy of the ligamentum flavum from disc degeneration. So disc herniation or bulging of the nucleus pulposus. It can also be due to osteophytes impinging, although less common. And then spondylolisthesis, or slippage of the vertebral bodies relative to one another. Now, radiculopathy, on the other hand, this is an impairment of the root, and it could be due to compression, and is most often the most common cause is compression, whether it's from a slip disc or an osteophyte. It can also be due to other causes like tumors, infection, inflammation. But we're going to mainly talk about the compressive causes. So the radiculopathy, impairment of the nerve root that is associated with radicular pain and symptoms of nerve impairment. And the most common causes are disc herniation and spondylosis or osteoarthritis. And the nerve root compression is due to narrowing of the interspinal central canal, the lateral recess of the neural foramen, similar to spinal stenosis. Now, it's important to keep in mind something here. Although these osteoarthritis changes, namely facet joint hypertrophy and osteophyte formation, are among the most common causes of radiculopathy, in most cases, their presence alone does not cause radiculopathy. Just because somebody has an osteophyte doesn't mean that it's going to cause symptoms. Another thing to keep in mind is that it's not always due to those facet joints hypertrophy and the osteophytes. So going back, and then lastly, I want to say something about sciatica. So this is also a term I hear a lot, especially in the clinic, and it's the term itself refers to a symptom complex of pain, numbness, tingling, and the distribution of sciatic nerve that radiates down the posterolateral limb and toward the foot. However, the thing is, sciatica is relatively nonspecific, and its general use has been discouraged by different expert panels because it's not really, it's vague and it doesn't lend much to the actual diagnosis or management of the symptom. Right. And then lastly, I want to talk about, well, not lastly, but I want to talk about nonspecific back pain. And so this is another one of those things of what lumbosacral radiculopathy is not. And it's important to keep in mind that sometimes we'll never know exactly what the cause is. And it's important to have this diagnosis in our back pockets because we need to be able to document what's going on and be okay with the uncertainty. So nonspecific back pain is back pain without an identifiable etiology, i.e. there's no pathoanatomical cause that can be seen on an MRI or EMG. And this also includes the term lumbar sprain, since the term in and of itself is can't really be measured or quantitative. And approximately 85% of people who present with back pain to the primary care clinic are eventually diagnosed with nonspecific back pain. And 70% of patients with nonspecific back pain improve within 4 weeks. Furthermore, it can be subclassified based on duration into acute, subacute, and chronic. So acute, less than 4 weeks, subacute, 4 to 12 weeks, and chronic, 12 weeks. And this is important for the management. So for nonspecific back pain, general management algorithm, patient comes in, do a history and physical, screen for red flag features, rule out other etiologies, counsel the patient. Once the red flag features have been ruled out, counsel the patient to continue physical activity and take NSAIDs as needed, and then also give them return precautions, and then follow up in 4 to 6 weeks. Hopefully, symptoms have abated and they no longer have the back pain. But we'll talk about what we do in cases where the symptoms don't go away. So back to lumbosacral radiculopathy, real quick. Lumbosacral radiculopathy is a clinical diagnosis for the most part, and it's made by looking for history and physical exam findings, but it's also important to rule out other more serious etiologies of radicular back pain. And that's why it's critical to look for the presence of red flag signs and symptoms, such as progressive neurologic deficits, urinary retention, site anesthesia, which could be which are associated with cardiac clonus syndrome, spinal infection, especially if there's patient has fever, or point tenderness, which indicates the tubal osteomyelitis. If they have a history of cancer, like prostate cancer, breast cancer, which could indicate that there might be a neoplasm that's causing the symptoms, or if they have a history of IV drug abuse or immunosuppression. And as a general rule, Patients who present with radiculopathy symptoms isolated to a single side of the body and a single spinal segment don't need urgent imaging, don't need imaging in general or surgical evaluation. They can be managed with conservative treatment and follow up within 4 to 6 weeks. And here in this image, we see a L4-5 disc that has posterior herniation into the spinal canal, compressing the dural sac. And it's important to keep in mind that imaging is not something we normally get right away, partly because most cases improve on their own, and also partly because there's poor correlation between what is present on imaging and symptoms in general. And with that, I mean to say a lot of patients who have these changes on imaging will not necessarily have symptoms, and a lot of patients who have symptoms may not have any clear pathologic etiologies on imaging, or may have imaging abnormalities that are inconsistent with their symptoms. Now, moving on, so as we said before, we want to do a history and a physical to diagnose lumbosacral radiculopathy. So after ruling out our 5 features, we need to consider the components of the history and look for certain physical exam findings. These include an inciting event or predisposition, like a history of cancer, or a patient who was lifting heavy boxes in the garage. And we also should look for pain and paresthesias, a longitudinal distribution, weakness localized to a single myotome, triggering and alleviating factors. So, for example, if a patient has relief when they're sitting down or hunched over, that can kind of point to the spinal stenosis as opposed to lumbosacral radiculopathy. And then when we do our physical exam, we want to localize and characterize the pain, sensory loss, weakness, and reflexes. It's important to also perform a straight leg test on both the side ipsilateral 2 symptoms and contralateral symptoms. And then diagnostic studies, these are generally not performed for run-of-the-mill lumbosacral radiculopathy presentation, but they are important if you see red flag symptoms, or if the patient has marked motor deficits, or if they just have this severe intractable disabling pain. That's also another important indication to pursue a more aggressive diagnostic strategy. Nerve conduction studies in EMG are generally not useful, but in cases where there's motor weakness and where the findings on imaging don't correlate with the patient's presentation, these can be done to show whether or not the symptoms are due to radiculopathy. So, for example, if there's if the EMG detects an abnormality in the paraspinal muscles, as well as in the muscles innervated by the peripheral nerve, like the femoral nerve, that points to radiculopathy. Whereas if the paraspinal muscles, if their innervation is intact, whereas the peripheral nerve innervation, such as femoral nerve innervation, is altered, then that indicates a peripheral neuropathy or a plexopathy. All right, and so here's some specific physical exam findings that we can look for. So to try and localize the nerve root being affected, we can focus on the sensory autonomous zones and specific motor deficits. So sensory autonomous zones are these zones that don't have appreciable crossover. So along the dermatomal distributions, there's going to be crossover between what is innervated by each successive spinal segment. And the sensory autonomous zones are reliably localized to one spinal segment. So the sole of the foot, they're consistently across people innervated by the S1 nerve root, dorsum of the foot, L5, medial calf, L4, anterior 5, L2 and 3. And then there's also certain motor deficits. So L3 and 4 are believed to mainly exclusively function with hip flexion without much interference from other spinal nerve roots. L5, dorsiflexion. So if a patient has trouble heel walking, that's specific to the L5. And then S1 foot eversion. So that's characteristic of F1, the S1. And here's another image kind of displaying the dermatomes as they appear when the person is hunched over. All right. And while making a radiculopathy diagnosis, it's important to consider other causes of the radicular symptoms, especially the urgent causes: spinal cord compression, caudate clungus syndrome, vertebral fracture, spinal epidural hematoma, especially in people on anticoagulation. And it's also very important to realize that these symptoms of back pain may not be radicular at all. And so things like an aortic dissection or abdominal aortic aneurysm can be a cause. A retroperitoneal hematoma, especially in an older patient who's taking anticoagulants, psoas abscess. All these are potential causes of low back pain. And here's a graphic from Up to Date that depicts one of the many different treatment algorithms. So the things you have to consider. And moving into the surgical or the management aspect of radiculopathy. So as stated earlier, generally the patient comes in with radiculopathy symptoms. They'll most likely recover within 4 to 6 weeks. And this is what they should kind of be prescribed a conservative management strategy, assuming they don't have red flag symptoms. And so, it's providers are justified in delaying imaging for this period of time to assess for spontaneous resolution of conservative measures. Now, these include things like continuation of physical activity with or without an exercise program. The data hasn't really shown a significant clinical benefit versus just continued physical activity alone. Cognitive behavioral therapy can also be important, especially if the patient has a history of back pain. Mindfulness-based stress reduction, and then also spinal manipulation. But also, so for these spinal manipulation, chiropractic, physical therapy, the data has not really shown a statistically significant benefit versus just continuation of physical activity. Analgesic adjuncts are available and should be given on an as-needed basis. So things like NSAIDs, ibuprofen, naproxen are preferred. Tylenol or Celebrex can be given if there's a concern for GI bleed. And then duloxetine or other tricyclic antidepressants can be trialed, cyclobenzaprine, Hosameddine. But again, these are not shown to be superior to NSAIDs, but they can be tried for depending on patient and provider preference. Generally, the use of opioids is strongly discouraged because of their harmful side effects. If opioids are deemed necessary, tramadol is a good place to start since it's a partial opioid agonist. All right, but then let's say the patients, they don't improve, so they come back 4 to 6 weeks later and they still have pain. This is at this point, it's more of a provider and patient conversation and treatment approach. So a lot of times it's reasonable to just say, well, let's wait some more time and the patient will get better. But sometimes the patient's in a lot of pain and they want to try something. So this is an option is analgesic injection, which is an injection of glucocorticoid and long-lasting anesthetic like Marcaine into the epidural space. Well, into the epidural space or other places. So epidural injections, facet injections can be used instead of osteoarthritis, an intradiscal injection, and a separate joint injection. These are options. And the thing about these is they can be therapeutic as well as diagnostic. They're not going to be long-term. They're going to be, provide relatively short-term pain relief, but they can be valuable for surgical planning in the sense that if you do a facet joint injection, find that significantly improves the pain, then that'll tell you that it's not so much radiculopathy as much as it is spinal osteoarthritis. So if the patient continues to have symptoms, then what do we do? So first, most importantly, it's important to kind of figure out what exactly is the cause of these symptoms. We don't want to do a discectomy only to find out that osteophyte is the cause of the symptoms. But if it is kind of seen that the patient has a slip disc, that the slip disc is causing symptoms, and that the symptoms that the patient is exhibiting are in alignment with the imaging and the findings of where the disc is impinging, a discectomy is a reasonable option for patients who have had prolonged symptoms. So there's the open discectomy, the microdiscectomy, and the minimally invasive discectomy. And although this is mainly for the discussion we had between the spinal surgeons, it's important for primary care physicians and neurologists to be able to talk to their patients about what the options are and just be aware of them and communicating with their colleagues in the surgery field. So the traditional open discectomy is performed with by pretty much removing part of the lamina, laminectomy, and then taking out the herniated components of the disc. The microdiscectomy is kind of a refinement of the open discectomy and has become the most common procedure. It can also be performed on an outpatient basis. It involves a similar incision, although smaller, and includes a hemilaminectomy, so removal of part of the lamina, and then removal of the disc fragment. And then there's the minimally invasive techniques, and these include the percutaneous manual nucleotomy, percutaneous discectomy, pretty much done through the skin, very little entry into the, very little removal of the lamina, and removes just the segments that are believed to be causing issue. Now, these are, on their face, very attractive. Very little, you have very little side effects compared to the open, but randomized clinical trials do not really show a significant advantage over microdiscectomy. And then also compared with surgery, compared with no surgery and just continued conservative management, there hasn't been really statistically significant difference in outcomes. And a lot of times patients, it seems that in retrospect, they may have been better served by just continuing watchful waiting. But it's important to have a discussion with the patient. And so here's another graphic for the discectomy. This is from Southeastern Spine Institute. And this is the minimally invasive discectomy, where they use a port to enter the epidural space and remove the herniated disc segment. And so herniation is a common cause of radiculopathy, but so is spondylolisthesis. And this is spondylolisthesis is a displacement of one vertebral body relative to another, most commonly anterolisthesis. So the superior spinal vertebrae moves forward relative to the inferior component, and this causes compression on the spinal spinal nerve roots. And this is the treatment for this is a laminectomy. It's kind of pretty straightforward. The lamina is impinging on the spinal cord and then nerve roots, and simply remove the lamina, and if needed, perform a spinal fusion to fix the vertebral bodies and prevent further slippage. And this is a good surgery both for radiculopathy and spinal stenosis. Here's another visual of it. And by and large, these are most typically most successful when they're done on a single intervertebral space. When they're done over more than one vertebra, they tend to have greater levels of complications. And then so let's taking a detour from radiculopathies into non-specific back pain. I stated earlier, close to 70% of patients with non-specific low back pain will improve with just conservative management alone 4 to 6 weeks. A greater percentage of them will improve with further conservative management, and about 1% actually have persistent symptoms and end up going on to receive surgery. Those who do, the most common surgery for chronic non-specific low back pain with lumbar disc degenerative changes is vertebral fusion, spinal fusion. And this involves removal of intravertebral discs, insertion of a bone graft, and then that bone graft will subsequently cause the vertebrae to fuse together. And this is a very commonly performed procedure, and although it's very common, the outcomes are not very guaranteed. It's important to talk to the patient that this may not completely resolve their back pain symptoms, and then also it may make things worse or come with its own set of complications. And this is also why it's very important to select the correct patient. This is not just something that should be offered to any patient with chronic low back pain. And the American Pain Society recommends that only patients who have had over a year of persistent, disabling, non-radicular low back pain be offered this procedure, and that the risks and benefits be discussed and that patient expectations be managed. A lot of times, most patients aren't going to get complete pain resolution with the surgery. And it's important for them to be aware of that. And then here's a new thing that's kind of coming out, or it's been out for a while now, is the idea of lumbar disc replacement. And it's a new alternative to fusion, because with spinal fusion, a lot of times the fused spinal segments, this will lead to degenerative osteoarthritic changes in the adjacent vertebrae. And this is obviously going to lead to worse outcomes for the patient, but it's kind of been shown that the use of a disc replacement as opposed to disc replacement with graft that causes spinal fusion avoids these degenerative changes and could also lead to a potential preservation of the range of motion for the patient. And this is obviously very beneficial and attractive to patients with these symptoms. And it's because it's relatively new to the field, there's currently insufficient evidence to recommend the procedure from the acute pain, the American Pain Society, but the FDA has approved disc replacement for relatively healthy patients who are over 60 years of age with disease limited to one disc between the L3 and S1 vertebrae. And so here's some images of the discs that have been produced here. There's a lot of different kinds and from different device manufacturers. And then lastly, spinal cord stimulation. So patients, they can have persistent disabling low back pain despite the use of several standard therapies following, or if they have back surgery and they still have pain in the failed back surgery symptoms or syndrome, the failed back surgery syndrome, which we've seen in the clinic with Dr. Burnett. Though there's no well-proven treatment available for these patients, referral to clinicians experienced in treating intractable back pain should be considered when standard interventions have failed. And then one of the things that can be tried is spinal cord stimulation. This involves placement of electrodes into the epidural space adjacent to the spinal area, presumed to be the source of pain. And an electric current is applied to achieve a sympatholytic or other neuromodulatory effects. And this is kind of done not so much to completely alleviate the pain, but distract from it. And by doing that, it does relieve the pain. And this kind of works based off of the gate control theory of pain. And so here's the leads we see in the graphic. There's an extension wire and a battery-powered pulse generator that's implanted in the skin. And this is something that can be offered to patients with intractable radicular pain. Also, patients with pain due to failed back surgery symptom syndrome, which can be axial or radicular pain, complex regional pain syndrome, and painful peripheral vascular disease. Something that's mainly used in Europe, not so much here in the US, but for intractable radicular pain and pain due to failed back surgery syndrome, spinal cord stimulation can be a good choice. But it's important to keep in mind and counsel a patient that complications are rare, but they can be severe. Things like a subepidural hematoma, spinal cord trauma, epidural abscess. All right, and that's the presentation. Here's the references. This is a very interesting topic for me. And if anybody has any questions, be happy to take those now.